Well, welcome everyone, and thank you for giving up your lunch for a talk about poop. To start, I'm a family doctor in Nanaimo, and I do mostly palliative care and geriatric care, so care in long-term care facilities and some geriatrics work in the emergency room. And I feel I have a couple of other unique qualifications. Besides being a member of the Therapeutics Initiative, especially with the educational working group, I also have a toddler and a cat, so pretty familiar with the topic we're discussing today. And you might be too. So what I want to do first, just for us to all sit and check in, is a polling question. And I want you to think about if you yourself have ever been constipated, had a child, a partner, a parent, a pet, or a patient who was constipated. And Chiprine's going to organize the poll so that you can let me know yes or no if they've ever experienced this or know anyone who has. You guys are fast. Wow. Normally when I do this talk, I make people stand up, and then they're only allowed to sit down after they've you know, completed the question, and their response is shown by sitting down if it's a yes and standing up if it's a no. So as expected, there's about 100%, about 72 people so far have answered. We'll just give it another few seconds here. Looks like almost everyone who's listening today has known someone with this problem. One person, no. Okay, that's a surprise. So I think we can probably stop the poll there. It's really helpful I think to do that, just to remember how common a problem this is. And if you look at various reviews on the subject, you'll see that there's a worldwide prevalence of about 15% for chronic constipation, and estimates of that number vary widely, but it's obviously a very common issue. And one reason that I wanted to talk about it and explore it is that I see a lot of patients who suffer from it, and it really affects many aspects of their life. There's some scary and really concerning things that it can cause, although those things are rare, like a bowel perforation. But most importantly, constipation is something that hugely impacts patients' quality of life. And yet it's not really a sexy topic. You know, there's not a lot of drug companies, research institutions dedicated to solving the crisis of constipation. So I wanted to know if the way that I was practicing was consistent with the evidence. And so I used some of my critical appraisal skills to look at this question. So I was interested specifically, and hopefully you are in adults, mostly elderly palliative patients, but along with normal adults with functional or chronic constipation, and also those who have opiate-induced constipation, which you might hear me refer to or in the handout as OIC. Then I was interested in what kind of treatments were out there, so mainly laxatives and medications or other interventions, whether by themselves or in a protocol or combination program, and how those compared in effect to placebos or other laxatives. And then lastly, looking at the outcome. So if we're using these laxatives or other medications in these patients, what are we trying to do? Well, with my patients, a lot of them, they're concerned about quality of life. So they want to feel well, they want to not have discomfort in their abdomen. Maybe they don't want to strain when they're having a bowel movement, and some are more concerned with frequency. So this is a log over here on the right. The top one is from a patient submitted to one of my colleagues, an older patient who diagrammed their bowel habits for a week or two. And there's also an app for that, don't worry, for your younger patients if they really wish to keep a close eye on this. The point of showing this is just to show that there's a lot of different things that might matter to patients. And so I didn't really know what I would find in the literature when I looked at that, but I thought I should kind of keep my span quite broad. So that's what I was interested in, and I'd like to share with you the answers that I found. The tough thing is that the evidence in this area is pretty poor. There are very few large randomized controlled trials. There are a lot of reviews, systematic reviews, and even network meta-analyses. And those are, if you're not familiar, those are kind of a review that looks at all of the available evidence and tries to compare so different interventions for one specific problem. So in this case, different types of laxatives for constipation, chronic constipation, where those laxatives have never actually been tried against each other in randomized controlled trials. So they're taking data from one study and another and trying to, through magic and math and statistics, try to compare them as if they're being looked at head to head with similar endpoints. But the problem with that is the randomized controlled trials that are out there are all pretty poor. Many of them are just 4 weeks long. Some are even shorter, just a few days in length. The longest randomized controlled trial, I think, was 6 months. But these have numbers of like 10 people to 200 people. There aren't very many that are quite large. And so when you look at all these systematic reviews and network meta-analyses, they're all looking at the same randomized controlled trials, of which there are very few, and they're all fairly terribly done. There's a lot of times where the randomized controlled trial didn't have a placebo group, so they compared some combination with some other combination, which makes it hard to interpret. And probably a lot of that is because many of these drugs were put on the market before the process of clinical trials as we know it today existed. So these drugs have been around for a long time. And you'll see on the right is, this is an article, the oldest article I could find was from the British Medical Journal. And that's from 1870, and in that it was just a letter, but they recommended using iron for constipation. We actually haven't come that far from there, but there has been some effort to define common outcomes and so on, and that was another thing that I found. My patients, they're all concerned about slightly different things, and these trials are all concerned about different things. So in some trials, they look at the Bristol stool chart, at the texture of the stool, whereas in others, they look at how many spontaneous bowel movements a patient was able to achieve within a week. Did they achieve more than 3? And did they achieve 1 more than their usual amount per week? So there's some more complicated statistics. Other trials looked at stool transit time, or they looked at patients' report of quality of life on very global scales. So there's a lot of heterogeneity in what's out there, and it makes it really hard to know what to do. And there's just not a lot done. In one of the Cochrane reviews, this line stood out to me as a really good summary of the evidence. It says there is still remarkably little research on this common and to patients a very significant issue of bowel management. And so I want to give you some caveats about I will give you what information I have, but I want to give you some caveats about it. Of course, this topic is prone to puns, and so apologies in advance for those that I make intentionally or unintentionally. When proceeding and trying to answer a clinical question with what evidence I found out there, I think the bottom line is that there's insufficient evidence to confidently guide your practice. So I'm going to just give you an approach that seems reasonable based on what I could find. And when working this way, you've got to be careful that there might be new information that radically changes what we do. That could be unlikely, but we're just going on the very, very tiny bit of information that we have, and so it's quite vulnerable to shift. So just keep that in mind as we go forward. All right, so constipation. What do we do? Well, usually how a patient presents to me is they say, "I'm constipated." They have that word already in their mind. And normally I ask them, well, what does that mean? Because I want to get a sense of how it's affecting them and their concerns. And it could be something like, I'm having trouble going as often as I used to, or I'm really straining, or some of my palliative patients will say, it's been 3 weeks and I have not passed a bowel movement, and I think that's probably something you should know about. There's quite a range of presentations, and there's no validated tool to assess this, although through expert consensus, the gastroenterologists who have a meeting every year to define these kind of things came up with the Rome criteria. And those include some of the things I mentioned, and also other things like the texture of the stool or a sensation of incomplete defecation. I'm not suggesting that you use the Rome criteria necessarily, but they might guide some of the questions that you have. And this criteria is occasionally helpful to distinguish between chronic constipation and something like IBS with a constipating subtype. So I don't want to put too much emphasis on this, but when I see a patient who's constipated, I ask them a little bit about what that means. And I usually do a basic abdominal exam and a digital rectal exam if appropriate. I also always want to rule out the red flags, and those are things you might be familiar with, like weight loss, bleeding, recent positive fit test, and also those patients who've been on most of the basic treatments and they've been adherent to them, and they seem to be unresponsive or not improving with the treatments that we've already tried. So all this is in your handout. There's a kind of algorithm there, and also it'll be on our website after the talk if you want to look further. In Nanaimo, we don't have access to testing for patients with constipation, really. I've never ordered manometry or balloon expulsion test. Occasionally in a patient where I think they're having issues with their pelvic floor or issue with their rectal tone, I'll do a digital rectal exam, and from that I can get some information that they might have pelvic floor dysfunction. But I don't want to talk about that too much today. Most of the time, you have patients and you can't get any kind of testing organized for them. So what's usually recommended from the expert consensus, from no particular evidence, is that you just proceed with trying some kind of laxatives for them. I think before you get to that stage, though, you want to think about, could there be some underlying or secondary cause to this? Some of those things, like hypothyroidism, might be treatable. Some others, even if you treat them, it may not really impact a person's propensity to constipation, something like diabetes, where good glycemic control really may not make a difference if they're already constipated. One thing that's really easy and very satisfying to do is to stop medications that are constipating. And I think this is really often overlooked. At the Therapeutics Initiative, we do a lot of work around polypharmacy, deprescribing, and we see these things called prescribing cascades, where a patient is given a drug like amlodipine, and then because of that drug, they wind up having swelling in their legs, and they're given Lasix, and they wind up to be constipated, which can be a side effect of both the amlodipine and the furosemide. So keeping that in mind, whenever I see a person who's constipated, after I do a history and physical, rule out red flags, I look at their medication list. And there's a lot of different drugs that can cause constipation. Some are fairly well known, like opiates, and others might be a bit surprising. And when I reviewed the literature here, couldn't find anything that said, if you stop drugs that are known to be constipating, a person's constipation improves. That's never been looked at, although it logically follows. But what's interesting is there's quite a range, and some things like NSAIDs, that was something that I've had patients tell me that were constipating, but I didn't realize that, compared to placebo, that was actually a relatively significant finding. A lot of the anticholinergic drugs and over-the-counter remedies that have anticholinergic actions are concerning for this. And we've got a therapeutics letter, a little bit about that can tell you how to look for those drugs and those effects. There's quite a list here, and I find, it's not always as easy as finding one of those drugs to stop, but certainly reviewing and seeing if any of those medications are present in your patient's list is worthwhile. And again, those are in your handout if you want to look a little bit more. So if your patient, say that they aren't on any of those drugs, or they don't have a reversible condition, and you just, okay, you're saying, I need to do something. I wanted to give them a laxative or something to help them. What should I do? Well, in my whole review of the literature, I found a couple of things that I think that I would sort of hang my hat on, or that I would say, this is the state of knowledge. There are actually no head-to-head randomized controlled trials that are comparing medications for chronic idiopathic constipation. Some of the data that you'll see, it comes from IBS data, it comes from other places, or it's from retrospective chart reviews. In the trials that I could find, there was no drug that was consistently superior to another one at improving these primary endpoints. And the endpoints varied from trial to trial. So it's not even comparing apples to oranges, it's like apples to durian fruit or something. The things that they're looking at are very different, but the most common endpoint is this one of helping a patient achieve at least 3 complete spontaneous bowel movements a week, which means they've had 3 poops and they feel like they've been able to completely evacuate their poop. That and or the composite endpoint of that plus having at least one more bowel movement a week than their average. So that's usually what the endpoints are, but not always. Most of the drugs, if you could calculate an NNT for them, they range somewhere between 3 and 15, but I don't think it's fair to present those numbers to you today because those endpoints are so variable and the way the trials were done, they're just too different to compare, although you see the network meta-analyses do provide some NNTs. There's no studies comparing the new drugs with the old drugs, which makes it difficult to interpret whether the new ones are better or just better studied. Certainly there's more funding in the new medications, and so you actually see more RCTs in the newer drugs. And then lastly, when I've done this talk before, a lot of people are asked about stepwise approaches or a bowel protocol like you see at the hospital. One of our colleagues would call it a diarrhea menu because there's so many different things on there and all of them can cause problems. That's actually never been looked at. So I can't tell you how effective that is, but I can give you some inferences based on what we do know. So we're going to dive into the data, and don't worry, there's not very much to go through. But it's all in the handout. So I think you guys can see me on the camera. So on your handout, there's this sort of table that has the different drug or intervention classes, a little bit about how they work, the side effects, and the best available evidence that I could find on them. So the first, yes.
Sorry to interrupt. I made a mistake and I forgot to tell people as they have questions, feel free to type them in the chat and I'll go through them as the presentation's going on.
Of course, great. Yeah, I hope we'll have lots of time at the end to address those.
Great.
So when it comes to the different interventions, I think a lot of the times fiber comes up as something that we recommend. And there is a little bit of evidence supporting that those with low fiber diets could benefit from adding some soluble fiber to their diet in terms of achieving those endpoints we talked about earlier. That said, fiber should be avoided in people with slow colonic transit time, which you can't always tell is present because you don't have access to the test. But generally that's your older, frail patients and also those with opiate-induced constipation. I think the reality of providing high fiber diets or supplements can be challenging. When I worked in Nunavut, patients there didn't have access to a lot of those foods, or it wasn't part of the traditional diet, so it wasn't really something we could incorporate. But I think if you have a patient who's really interested in doing everything in their power, it's worthwhile. And you'll see some of the studies there. Most of them are with psyllium husk versus placebo, and they do show some benefit to using that. But there are also some negative trials. So I don't think it's it doesn't solve problems for people with great difficulty, but for someone with a minor presentation, it's certainly worth a try. Exercise, there's a few RCTs, but they're not really controlled. You can't control very well for that, but there was ones comparing different types of exercise and things like that, and a large number of studies from China, and there's some correlation perhaps that exercise could improve the number of bowel movements a person's able to have. We don't really know the mechanism of that. And again, for my patients who are mostly frail and older, they're already doing everything that they can to keep moving, and many of them are not able to do that. So it may not be realistic. Fluid intake, that's one that I think we push a lot, but again, the literature really isn't there. There was one study in long-term care residents that showed if they were quite dehydrated, that water could make a difference to the frequency of bowel movements, but it's not something that's really been looked at. So I never push these too hard with patients because usually they've already tried them, or it may not be appropriate for my specific patient population. But if you have younger, fairly motivated individuals, not a lot of harm with these things, but I would just be cautious to stay away from fiber in people with slow colons. Stool softeners. This was kind of nice because most of the evidence I found was very uncertain, but there seemed to be consensus within the literature that stool softeners like docusate are not useful. These have been compared to psyllium and to fiber and found to be inferior. There aren't any, I think there aren't any RCTs directly of this compared with placebo, but they looked at other, for number of bowel movements, frequency of bowel movements, but they looked at other things like stool colonic stool transit time and texture of stool and other things like that, and these seem to make no difference. And so generally I recommend staying away from these because it just adds pill burden to a patient and may not have the effect that they're hoping for. The osmotic laxatives, those are probably ones that you're familiar with it. So that would be like polyethylene glycol, PEG, brand names like Restoralax, lactulose, milk of magnesia. And this is where most of the evidence is available. Cochrane has a few reviews, and a lot of the evidence that they gathered there is from the pediatric population. These work by stimulating increased fluid into the bowel lumen, which then allows easier passage of stool. And so you can imagine some of the side effects. I mean, diarrhea is pretty well a side effect of all the different laxatives and other types. With these, there can be some flatulence and dehydration. It's pretty rare, except with large volumes. So the sort of bowel prep before colonoscopy type volumes. In the studies here, all of these drugs have been found to be superior if compared with placebo, although some of them aren't. The difference between the different drugs is just tolerability. So lactulose is very sweet tasting, and so a lot of people find that difficult to take, whereas PEG or polyethylene glycol has no or very minimal taste, so most people find that easier. And in terms of cramping, flatulence, those types of side effects, PEG seem to come out consistently as most tolerated. So that's probably one of the strongest reasons to recommend that. One challenge in British Columbia is that under the palliative benefits plan, polyethylene glycol is not covered. So patients have to pay for that over the counter. So if your patient doesn't have, you know, $15 to $20 a month to spend on PEG, you might be looking at considering an alternative in this drug class. The stimulant drugs. So Senna has been studied only as an adjuvant. So that's how it's often used in practice, is in addition to other laxative drugs. There aren't any trials that compare Senna to placebo, but when it is used in combination with something else, Senna plus placebo, or say Senna plus PEG versus just PEG alone, there is evidence that the combination is superior. So it's felt that Senna does have some effect. It's pretty well tolerated, and there was this one big meta-analysis that looked at the bisacodyl and sodium picosulfate, and both were effective, and I think they were found to be the best drugs in that whole network meta-analysis at 4 weeks. However, there were some problems with tolerance of the bisacodyl. So these are drugs that we think that they work. They're relatively inexpensive, and they're fairly easy to give. So they might be already something that's in your repertoire. And the stimulants, including Senna, it's available over the counter, but it is also covered by the palliative benefits program. Now we're going to get into a little bit more complicated stuff. The patients that I see who have constipation, many of them are also on opiates. So a large part of their constipation, in addition to being maybe immobile, is the opiate use. And for opiate-induced constipation, there are some unique treatments. These are the opiate reversal agents. Some people call them PAMORAs. That's peripherally acting mu opiate receptor antagonist. So they reverse the action of opiate in the gut, but they don't reverse the action of opiate in the rest of the body. So they don't reverse the analgesic effect. And those medications have been shown to be effective at increasing the number of spontaneous bowel movements people can have, as well as not reversing the analgesic effect. One of the most effective medications in one of the network meta-analyses was naloxone, but unfortunately that one is not just peripherally acting, that one's also centrally acting, so it does reverse the analgesic effects. So in a patient who's on chronic opiates for cancer-related pain, naloxone probably wouldn't be a good fit. Of the ones that are available in Canada, there's the methylnaltrexone, which is the subcutaneous, the injectable version. The brand name of that is, I think, Relistor. And then there's the oral one, naloxegel, which is, the brand name is Movantik. Now, these drugs are very expensive and they're not covered by the palliative benefits program. They've never been compared head-to-head with traditional laxatives, so we don't know if they're any more effective. We know that they are probably effective. The number needed to treat in the trials ranges from 4 to 15. So we think they might be helpful. However, we don't know if they're superior, and they're so expensive. You know, using them for a month could be $300 to $400. So generally, these are recommended as a kind of rescue medication if all other things are not effective. Many people haven't heard about these drugs, but I wanted to show you some of them because a few of them are available or coming available in Canada. The chloride channel activators and the guanyl cyclase C agonists, those are both considered secretagogues. They have each have their own mechanism, but basically it results in more fluid being in the lumen of the bowel, helping the stool pass. Lubiprostone, I don't think it's on the BC formulary, but I believe it's approved in Canada. And it has a few randomized controlled trials that show that it increases spontaneous bowel movements, but it hasn't really been tested in opiate-induced constipation, so it's not recommended there. And it has the typical nausea, diarrhea, headache, like a lot of other drugs. The guanyl cyclase C agonists, those I think, they're not covered on Plan P. I think that linaclotide is available in BC. And again, there's some placebo-controlled trials that show it's superior to placebo. In this case, they were looking at the need for additional laxatives after giving that. But again, it hasn't really been looked at in opiate-induced constipation. The 5-HT4A antagonists, the prucalopride is probably the one that you would see more of. Tegaserod is one of these drugs that was originally approved but pulled due to a concern of increased cardiovascular risk, and reintroduced to the market for young, healthy women without cardiovascular risk. And prucalopride is probably considered safer from a cardiovascular perspective because it's more gut selective in how it works. And these ones seem to stimulate peristalsis and bowel motility. And again, there's a fair number of trials here, probably because these are a newer drug. I think there's 7 RCTs in total. 6 of them show that these are more effective than placebo, but those were all short trials. I think 6 weeks or 8 weeks was the longest in the group of the positive trials. When you look out further than that, it was at 24 weeks. There was no difference between this drug and placebo in terms of achieving the spontaneous bowel movements. So in terms of enduring effect, wouldn't be convinced about that, but there may be specific places where these medications have a role. I think we're going to see more if and when they all come to the Canadian market and they're tested. But right now, these are being marketed mostly for IBS-related constipation. And some of them, like the 5-HT4A antagonists, may have a unique mechanism of decreasing the sensitivity of the gut so that people experience less of the abdominal cramping pain that goes along with their IBS type constipation. So there might be other mechanisms of action that we don't really understand yet. Suppositories, enemas, and disimpaction, those are often used, but pretty poorly understood. There's a little bit of literature on their efficacy here, but the one biggest study I could find was a trial in a long-term care facility where patients were given oral laxatives, and then some of them were randomized to receiving suppositories and enemas. And the patients in the group who received the rectal treatments had more empty rectums on exam. That was the extent of the trial. The rest of the literature was looking at pediatric populations receiving these in the emergency room setting. And they found that there was effectiveness initially to help the patient pass their bowels. However, in follow-up, the patients who had these treatments were more likely to return to the emergency room, perhaps due to discomfort, complication, other things within the first few days after receiving them. So these still probably have a role, but it's not an evidence-based one. It's one that would be informed by your clinical experience more than anything. So just to reiterate, I know it seems like coming to a talk about, you know, you kind of want to know what the science is and what should I do. And we know so very little about which drugs we should use, what order we should use them in, how long we should use them for. And I know that can be very frustrating. So I thought I would wrap up by showing you just a couple of the things we don't know and a couple of the things that we do know. So what we don't know is, unfortunately, almost everything. We don't know how these drugs work for things that matter to patients. You know, patients are not involved in, or we're not involved in the designs of any of these RCTs in terms of selecting the endpoints. We don't know how the new drugs compare to the old drugs, or even what doses we should be giving. Don't know how long to give these medications for, although if you look at the PEG literature, you'll see there is a retrospective chart review that shows some enduring benefit at 24 months, so 2 years. Whereas that wasn't present with some of the newer drugs like the prucalopride, where at 24 weeks, it wasn't found to be superior to placebo. We don't know if combinations have an additive benefit or some kind of synergy that goes on through targeting different mechanisms. And we don't know if stopping constipation drugs would lessen constipation, and so on. I could go on about all the things that we don't know. But we need to do something. I need to do something. I see these patients every day. So I think it's fair to say, you know, we should always deprescribe where possible. And I think a person presenting with constipation is a great opportunity to do that. And you'll see the expert consensus from the European guidelines and so on will say it's reasonable to stop any constipating medications first. And you're always welcome to try those conservative measures like fiber, fluid, and exercise with patients. I just find the yield in practice is fairly low. And so once those are exhausted, trying some kind of medications, we know that they all increase the frequency of bowel movements except docusate. So you could start really anywhere, but I think it makes sense to start with something with the least harm. So the thing that's going to be best tolerated and that's the least expensive. So that's probably the osmotic and stimulant laxatives first. And that's what all the network meta-analyses and so on seem to suggest when they include those older agents. So we have another poll to see if you're still with us. And I'd also be interested in your practice. I want to ask you whether you recommend laxatives to all your patients that you start on opioids. So this could be a palliative patient or a patient presenting to the office with back pain or starting an opioid for them. Do you normally give them a prescription? Yes or no? Well, you guys are really fast again. This one's coming out. This is not quite as black and white as the first poll. So I'm seeing almost 50-50, about half of the people. 38 people so far say yes and 34 are saying no. And that's really interesting. I learned in medical school and being a palliative care doctor from a lot of my mentors, it was the hand that writes the narcotic script, writes the bowel order. And some of you may have heard that as well. I think we'll end the poll there. And I can tell you, I'm sad to say the evidence around what to do here is also pretty well absent. So I looked to figure out where we got this recommendation from. It's mostly expert consensus, but there was one study in Japan. They pulled the charts at different institutions of about 620 people, and they excluded a lot of different groups, and then they looked at, did the people who received scheduled sort of bowel care compared to the people who weren't given that initially have higher reports of constipation. And the way they define constipation in that study was no BM for 72 hours within the first week of receiving the opiate. And in that case, they found, yeah, the people who received laxatives were less likely to have constipation by that term. There are some other retrospective reviews that support that idea. This one was actually the most rigorously done. So we're kind of making it up as we go. Personally, I think it's reasonable to offer, and if the patient declines, that's fine, but I always warn them of the anticipated side effect of constipation, which seems to occur in about 90% of people who are on opioids. So The other thing that I do in practice, I just want to show you what I might do as a prescription. So actually, I did a house call on a guy 2 weeks ago who had his main issue. He has lung cancer, which is progressing, but his main issue was this constipation. He found it very frustrating, challenging to deal with, and didn't know what to do and where. So what we did there, he was still taking amlodipine and calcium. I'm not sure the reasons. Actually, there was one other, I think another diuretic he was taking. So I would start by looking at that and stopping those unnecessary medications. Those were not consistent with his goals of care, and they weren't actually medically necessary. And then I suggested starting PEG because he was able to pay for that. But if he didn't have the means to do that, I probably would have started him on Senna regularly because it's fairly easy to take. And in the case of, if I start PEG, I usually offer a prescription for Senna, which is covered by the palliative benefits as an as-needed or rescue type medication. That's how, in some of the cases, in some of the trials, how it's been looked at. I think it's very reasonable and pretty well tolerated. And I think the key thing here at the bottom is following up. So I'm lucky to work with nurses who will follow up and check in with the patient that they feel that's adequate. But that's not always possible. So that's a whirlwind tour of everything to know about constipation. I thought I would turn it over to Erin, who's been gathering a couple of questions.
Great. Thank you so much, Jessica. That was a great webinar. Just a few things before we get to the questions. You will be emailed an evaluation form to complete if you wish to receive credits. Even if you don't want the accreditation certificate, there's some important information that we can learn from you through the evaluation. So we encourage you to fill it out either way. I have a few questions to ask. The first one, Jessica, is have you had any experience with using injectable naloxone orally for short-term use as a rescue?
Using injectable, I've never done it because almost all my patients are on pretty significant doses of opiate, my palliative patients who have this problem. Having seen naloxone used in that setting, I think it's pretty cruel to reverse someone's pain control. If it's a patient who's not on significant amounts and you have maybe other reasons to use it, sure. Sometimes in our community, we've been able to access the Relistor, methylnaltrexone, or the oral naloxone, occasionally through compassionate means or something like that. And for a brief time, it was on formulary, I think, at our hospital as some kind of trial. So I have used those medications with some effect, but because they're not readily available, so far I've been able to manage all my patients in the community with basically just the kind of basic, the Senna and the stimulants and the osmotics. It's certainly something you could try, but I would probably want to do that in a monitored setting.
Okay, great, thanks. I have another question. Any specific recommendations on what to choose for constipation from SNRIs? Oh,
that's a really good question. I didn't review that literature, and you know, I think I'm looking at tramadol right now. I'm doing some reviewing on that, which has an SNRI type action. But no, I don't know if that's ever been looked at. I think there's obviously some more cautions with interactions with some of the newer agents because I don't know if the drugs like the precalipride have been studied. So I might be careful about that because I just don't know very much about it. No, I think we have no information. So I would think using the traditional stuff would be still a reasonable first way to approach it.
Okay. Thanks. One comment, observation that oral naloxone should not be absorbed and should not reverse the opioid analgesic effect. So just a comment from one of the participants.
Yeah, and if that person could email me after, it would be really interesting because I found some interesting detail about that that we could discuss offline. Okay,
great. The next question, have you used any of the following in a pediatric population, prucalopride, linaclotide, or lubiprostone?
No, I have not. And you'll see for linaclotide specifically, there's a black box warning about death due to dehydration in mice. I don't think any of those are approved for pediatric use. Some of them aren't even on the market in Canada yet. My population is not pediatric. And again, so I didn't look at that literature specifically, but I think caution would be advised. Most of the trials are so far that inform this whole topic are related to polyethylene glycol in children. That's obviously the mainstay, but I know there are cases where rescue would be desired, but I think there would be more needed to be done before those other medications are approved for children.
Okay, great. We have 2 minutes left. There's 3 questions in the queue, so I'll try to get to them quickly. Any evidence for using multiple osmotic agents, for example, PEG and lactulose together?
Yeah, that's an interesting question because that's how I was taught to prescribe them, and that's what's on our hospital bowel protocol. However, no, they work in the same mechanism. So I think the reason for doing that would be tolerability. So if a patient can't drink a large volume of fluid that's required to take the PEG, then using something like lactulose, you might be able to get an equivalently higher dose more quickly into the patient in a way that they're able to tolerate. So I think only in terms of like if they're just having trouble tolerating one form or another, or if they prefer milk of magnesia, but it's just hasn't been effective enough, you could dose them with another, lactulose or something like that. But no reason specifically to do that other than patient characteristics.
Okay, great. The maximum dose of Senna you would use in 24 hours?
Yeah, that varies in the studies. I think the highest I could find in the studies was 36 BID. I think that's where they define the treatment failure. In practice, I've seen and used more than that on rare occasion. Sometimes the patient just wants that. And so occasionally we'll try it, but you just find that you're limited by the side effects, particularly cramping in that case. So usually when I get up around, a couple of tablets or 3 tablets, 3 times or 2 times a day, you're starting to wonder if there could be something else going on as well. So that might, in your non-opiate induced or your other patient, you might start thinking about, am I missing something here, or should I try another agent? Maybe this isn't working for this patient.
Thanks very much to Dr. Otte and for all of you for attending. Have a good afternoon or whatever time of day it is, wherever you're calling in from. Thanks, everyone.
Thank you. Please feel free to email, and I'm happy to follow up with your questions that we didn't get to.